Good morning. Good morning. Good morning. This is Patience. I'm back again on maternity nursing. Maternity nursing. Today, I'm talking about newborn care. Newborn care after delivery. This is going to be the last video on maternity nursing. So I'm going to talk about newborn care. So after a mother have gone through the process of labor and have struggled and the baby is out, how do you care for this newborn? The baby is a newborn. How do you care for the baby? Mind you, when you watch these videos, you have to take notes for yourself. I am not giving notes from this. You have to take notes for yourself. It's there as content review for you just to hear and remind yourself of what NCLEX is going to test you on. You need to practice questions with your knowledge of the content. If you know the content and you are not practicing questions, I advise you to put it into practice because you're going to need to practice more questions to be successful on the NCLEX. So whilst you know the content, you have to put it into use. Now let's go straight to our newborn care. So when you are caring for a newborn or you are in the labor unit, you have been assigned as the nurse on the labor and the delivery unit, and a woman just give birth, your priority concern right now is to promote the health of this baby and to help this baby to develop or to be in a safe and in a sound position. You want the mother to also feel comfortable that the baby is being taken good care of. So initially, after the baby is born, when you are able to help the mother deliver the baby, you want to assess the baby. So you want to observe or assist with initial respiration. So some of the babies are born and they are gasping for air. You want to be able to suction. Remember, I told you the other time in the previous video that in the, I think that's postpartum period, you have to suction inside the baby's mouth. And then before you suction inside the nostrils with the same bulb suction. So you have to assess the baby's respiration. You have to check if the baby came out and is able to breathe. Now you have to assess the ABGA score. The ABGA score is done in the first 1 minute and the next 5 minutes. So initially you want to see how the baby is responding outside of the womb. So you want to note the baby's cry. Is the baby crying strongly? You want to monitor for nasal flaring or grunting, retractions and abnormal respirations, such as seesaw respiratory pattern, the rise and fall of the baby's chest and the abdomen. And you do this, the rise and fall of the baby's abdomen. And this does not occur at the same time. How the baby's chest is and the abdomen, it should not be at the same time. You have to monitor them different. And then you have to make sure they are all in order. It's not like the baby is kind of grunting and struggling to have in deep air into the lungs. Remember, the baby is still new to the environment and everything is new in the first few hours of life. But immediately the baby comes out, you want to make sure that baby is breathing. So you want to assess for cyanosis. You want to assess if the baby looks a little bluish than normal. So you obtain the vital signs of the baby as well. You want to observe the newborn for signs of hypothermia or hyperthemia. The temperature, remember the baby just came out from the mother's stomach, the mother's womb, and the womb was warm. So when the baby came out, you want to assess the baby. Is the baby's temperature within normal limit? Is it too cold? Is the baby too hot? You want to assess that. That's why you quickly clean the baby out of the fluid and then you wrap that baby up. You want to assess for gross abnormalities. Anything that does not look normal, anything that does not look usual for a baby to have. You want to assess for that gross abnormalities. Then interventions, suction the mouth first and then the nose if needed with a bulb syringe. So I have said that over and over. Then you want to dry the baby and stimulate cry, rubbing the back. So if the baby came out and is not crying, you want to stimulate them to cry by rubbing them in their back. It's not beating, okay? You are not beating the baby. You rub their back to have them cry, because you want them to cry to be able to close the airway system and they will be able to breathe on their own. So you want to maintain their temperature stability by wrapping them up in a warm blanket. And you want to keep the mother and the baby to bond. So you put the baby on the chest of the mother or on the abdomen of the mother. And at that point, a baby who is well sound with a good Apgar score, no cyanosis, no difficult, the baby will start looking for the breast. You will think that baby is too tiny for that. You want to place them at the mother's breast if breastfeeding is planned, especially. So you see the baby start looking for the breast milk, the breast to suck. So you want to place the baby in a radiant warmer, and then you ensure the newborn is properly identified. Listen, when you are delivering a baby, your other risk for concern is that another woman is also delivering another baby. You're going to have this baby tagged with the mother's name so that identification will be easy. So remember, it's a crucial step as well. In as much as you want that baby safe, you want that baby assigned to the correct mommy. So you want to footprint the newborn and fingerprint the mother on the identification sheet paper. Identification sheet based on the agency policy. Based on the agency policy and procedure, you want to print the mother's fingerprint and the baby's footprint, and then you put it on the sheet. So you place the matching identification on both baby and mommy. Now let's see the Apgar score system. So like I said, assessing each of the 5 times to be scored, each of the 5 items. So the Apgar score has basically 5 items on it. It has 5 items in it. So because the Apgar score has 5 items in it, let's see what these items are. Let's see the items of the Apgar score. So Apgar score has 5 components of it. I'm going to share my screen and then I can type it. So the A stands for the appearance, the baby's skin. How does the baby appear? In general, does the baby look normal to you? Does the baby look healthy and normal to you? That's the A. So A is appearance of the baby. Okay. So I have shared my screen on the Apgar score. I have a screen shared on the Apgar score. So with the Apgar score, the A is appearance, P is pulse rates, G is Grimax reflexes, and the Grimax is also about the reflexes, the baby's reflexes. I will discuss the different types of reflexes that newborns come with very shortly. And respirations is the R. A is muscle tone. So usually the Apgar score is done in the first 1 minute of delivery and then the next 5 minutes after delivery. So even if it's normal, you're going to repeat it in 5 minutes to confirm that it is normal. So subsequently, you might need to repeat the Apgar score more than 2 times. More than 2 times. You can do the Apgar score up to 3-4 times if the responses were not good. So the first one, if the baby score less than 8, from anywhere from 0 to 7, you want to repeat this Apgar score more than once. You want to repeat it more than once. So for an Apgar score, this is an Apgar score of 8 to 10, there is no intervention needed. You just need to be supportive, and that means the baby is responding spontaneously on their own. The baby has a strong cry. All the reflexes are responding good. The Grimax, the baby is able to hold. You see the hands holding. The heartbeat is greater than 100. The baby is responding well. So you are not really concerned with this. So, and when you look at the muscle tone, the baby's muscles, the baby is moving. You can see the baby jacking out, and as normal as a newborn should move. So with the skin will not be pale. It will look pink. That is usually the normal skin. There's no cyanosis. So breathing, the baby will be breathing regularly, and it will be just good as expected. You can count the respirations, and the baby is breathing very well. So in that case, you don't need to do any intervention when the score is up to 8 to 10%. Please look for a table and review this. But this should be enough for the NCLEX, especially if you're doing the LPN. Now, for a score of 4 to 7, you want to stimulate the baby, you want to rub their back. This baby will need an oxygen. The baby will have maybe the reflexes or the baby's muscle tone, or the baby's skin color will look a little bluish. Baby might need oxygen. The baby's skin color is a little bluish, you want to administer oxygen. If the baby is not able to hold your hand, the reflexes are not so strong, the grimace is not working right, you want to also support them with oxygen. And if the heart rate and the respirations are slow, all that you want to administer oxygen, and you rub their back, you want to stimulate them. You want to rescore them at specific times. So you do the first 1 minute, this is what you get. Let's say you got 6, you have to repeat it in 5 minutes. And after 5 minutes, you have to make sure if the 5 minutes on move up to 8, you still want to come back and do it. The same thing applies if a baby is 0 to 3. A baby of 0 to 3 means most of the reflexes, most of the ABGA score components are just not responding as normal. Most of all this will just be scored maybe 1, 1, or some will have 0. The baby may have 0 of some. Assuming the baby grimace reflexes are 0, baby doesn't respond. The baby is not able to hold your hand after delivery. The baby's breathing is absent. There's no breathing. Imagine newborn come out and not breathing. You score them 0. The muscle tone if it's weak. So at the end of the day, if the baby cannot respond up to 8 or cannot respond above 3, you want to resuscitate them. This baby might need resuscitation. So you have to do your resuscitative measures for newborns. Usually they call that NRP, neonatal resuscitation with this thing. So you have to resuscitate this newborn. You have to recheck the ABGA score probably more than 3 times to make sure that each time you provide an intervention and you come back, the baby is responding. The baby is responding. So these are the actions you want to take for your ABGA score. Please keep learning and study more of this. We have more of the ABGA score to learn. This is not all of it. If you want to understand the basic component of the grading scale, I am not going into detail with that. I assume you already know this. I was just picking it up, but I assume you already have this in mind because you are already preparing for the NCLEX. It tells me you are just in need of a review. You are just reviewing all this content. So that is what I am doing. I am just reviewing the content with you. So go get the whole thing and study. But just know the fact that, especially if you are doing LPN, just have it in mind that the first 1 minute and the first 5 minutes is when the ABGA score is assessed. So the newborn's ABGA score is routinely assessed and recorded in the first and the next 5 minutes after birth. And it may be repeated if the score is low. And even if it remains low, you cannot say, I repeated it twice, I wouldn't do it again. If the score was low, you want to repeat that. So you start with a general observation of the baby as the nurse. You wanna be able to initiate interventions for abnormal findings if the baby is not responding. You want to be able to grade the baby on the ABGA score scale, and you want to let the doctor know a neurological criteria. You want to note their neurological function. So the phrases of newborn stability, To be able to stabilize a newborn, usually you want to stabilize their stability occurs in the first 6 and 8 hours of birth. So when they are born, the first 8 hours of birth, they are existent out of intrauterine, out of the uterus. Their existence outside of the environment instead of the uterus is what you need to be very responsive about, very careful in caring for them, because that's a crucial moment. They have to adjust to the outside world of their usual place of being in the womb for 9 months. So the first 6 to 8 hours is what you need to critically monitor every physiological changes in your newborn. So their vital signs, their heart rate when they are resting, when the baby is resting, is 110 to 160 beats per minute. So 90 to 110 beats per minute if the baby is sleeping. Immediately after birth, if the baby is sleeping and their heart rate is 90 to 110 beats per minute if they are sleeping. And if they are crying, their heart rate will be up to 180. It is not tachy. Don't consider that as tachy because the baby is crying. Now, the heart rate is usually checked apical. You do apical pulse for them. So you have to auscultate the baby's intercostal space if for 1 full minute to detect any abnormalities. That is the newborn. Now let's talk about the newborn respiration. The newborn respiration. So the respiration is 30 to 60 beats, 60 breaths per minute. The newborn's respiration is 30 to 60 breaths per minute. So you want to assess that for 1 full minute. And if they are breathing between 30 and 60 beats per minute, it is normal for 1 minute. Then you want to assess their heart rate and respiration rate first before assessing other vital signs, before you do the other vital signs and when they are resting or they are sleeping. So we have the axillary temperature. We have the axillary temperature, which is, it should be at least 97.7. And then it should be less than 100.3. You don't want them to have a fever after birth. Let's talk about blood pressure. Usually, it's not done in 10 babies, in 10 newborn babies, unless a cardiac issue is suspected. So 80 to 90 over 40, like 80, let me write this down. So a baby's blood pressure of 80 to 90 over 40 to 50 is normal. So unless they have a cardiac problem, but when you have a blood pressure of this in a newborn, it's okay. But if there's an issue with the cardiac assessment, that's where you do their blood pressure. So 80 over 90 and then 40 to 50 is fine, but it's not usually done. So body measurement. So approximately the length of a newborn should be 18 to 22 inches. Newborn, 18 to 22 inches is fine. And if you want to have that in centimeters, it's going to be 45 to 55 centimeters. That is fine for a newborn. Their weight, the normal weight of a newborn should be 2,500 grams to 4,000 grams. And when you convert that, that will be 5.5 to 8 to 8.75 pounds. This is the normal weight for a newborn. And their head circumferences should be 33 to 35. This head circumferences. And 3 to 35 centimeters, or it should be, let me write that, centimeters, or it should be 13.2 to 14 inches. This is the head circumference of a newborn. The head circumference of a newborn. So take notice of their measurements immediately after birth. So this one is weight, and this one is BP for the newborn. This one is their height. Is that their height? Yes, I think. The length. Okay, it's the same thing as height. So this one is the length of the newborn. Then this is the weight. I put that down already. Then this one is the head circumference. Head circumference. So that's the measurement of the. So let's talk about the head. The head. So at this point, I'm going to talk about the newborn from head to toe. So the head. So the head should be 1/4 of the body length. The head of the newborn should be 1/4 of the baby's body length. Okay. So usually, let me pause the sharing and then we can continue talking. So the rest, I would prefer you take some notes on that. The head should be 1/4 of the baby's length. The bones of the skull are not fused immediately after birth. You have the sutures that are tissues between the skull, and they are palpable and may be overlapping because of the head molding. You know, the head has to mold when the baby is coming out. It has to mold to shape it enough to be able to pass through the vagina or through the cervix. So it is not widening, it has to mold, but they are not fused to each other. The fontanelle. So the baby has two fontanelles. We have one right in front, the occipital and the frontal lobe fontanelle. So the front one will close in 18 months. When the baby is 1.5, there's a fontanelle right here. It closes 1 to 18 from 1.5 year. So if the baby is 18 months, this one closes, but this one closes within 6 months of birth. So that's it about the fontanelles. Let's look at the head. Let's look at the eyes, the baby's eyes. So the baby's eyes have to slate gray if the baby is a light skin, dark blue, or brown gray with a dark skin baby. The eyes has to be symmetrical. The pupils has to be equal. It has to be able to react to light and accommodation. Blinking reflexes should be present. The eyes should be crossed because of weak intraocular muscles. And there should be ability to track and fixate momentarily. You see them tracking and then they stay fixed for a moment. Sometimes you see them just like that. Don't think they are personal. Let's talk about the ears. The ears of the newborn should be symmetrical. There should be firm cartilage with recoil. You tap the penile on or above line drawn from outer canthus of the ears. There should be low set ears, which is, if the baby has a low set ears, is associated with Down syndrome or renal abnormalities or genetic chromosomal disorders. The nose should be flat, broad, in center of the face. You can't have the nose here, okay? It should be flat, broad, and in the center of the face. You don't want the nose on the other side of the face. So it should be able to breathe. The baby should be able to breathe through the nose. The nares are patent and should not flare. There should not be nasal flaring when you assess the nose. And if there is nasal flaring, it means the baby is having respiratory distress. Let's talk about the baby's mouth. The mouth will have to be pink, moist, gum, soft, and hard palate. That's the mouth of the newborn. And the uvula should be midline. The uvula is the one on top. It should be midline. It's all the way to the back, and it's like protruded down. It should be midline. The uvula should be midline and freely moving tongue like this. And it should not be thick. Some babies have their tongue stuck to the bottom, and sometimes they have to surgically manually cut it. If not, they will not be able to speak. They usually have delayed speech. Sucking and crying movement should be symmetrical, and the baby should be able to swallow. Root and gag reflexes should be present as well. So when you're assessing a newborn's mouth, you want to look for the presence of thrush or candida albicans, which are white patchy areas on the tongue and the gums that cannot be removed with a white cloth. This may be painful. We look for patchy stuff, abnormality in the baby's mouth. Let's look at the neck, the baby's neck. So the baby's neck should be short and thick, head held in midline. The head should be able to hold in midline, even though at that time their head is not really stable, but it should be able to be straight. The trachea should be midline. The trachea should be midline. Good range of body motion and ability to flex and extend. You assess for torticollisa's head inclined to one side as a result of contraction of muscles that are on the side of the neck. So you want to assess for that. It is not an expected sign. Now let's talk about the chest, the baby's chest. The baby's chest has to appear circular, and it has to be approximately 30 to 33 centimeters. That is 12 to 13 inches at birth. The diaphragmatic respirations, chest and abdomen should rise and fall in synchrony. It has to be well synchronized, not in a seesaw pattern. You know, seesaw, one will go up. So whilst one is going up, one is coming down. And whilst one is coming down, one is going up. That's the seesaw pattern of the chest rise and the abdomen fall. Chest and abdomen rise and fall. The bronchial sounds heard on auscultation, there should be bronchial sounds. Nipples should be prominent and often edematous, milky secretions, which are common. Okay, so when you have some milky secretions coming out of the baby's breast, is common. Breast tissue should be present. Clavicles need to be palpated to assess for fractures. This is the chest. Let's talk about the skin. Should be pink red, light skin newborn babies. It should be pink red in light skin newborn babies, or pinkish brown or pinkish yellow in dark skin newborn. So the black babies and the white babies. The vernix caseosa, a cheesy white substance in preterm newborns, is more prominent between their skin fold. Okay, when they get closer to term, when the baby is closer to term, you still see a lot of the vernix caseosa on them, and it may be present after 42 weeks of gestation. So if the baby is moving all the way to 42 weeks, that's overdue. You will still see the vernix caseosa, but it starts clearing off around that time. We have the lanugo, that's the fine hair that is seen on the babies, especially on their back. You see that they look hairy when they are born. So that's the lanugo. They will have dry peeling skin that increases with post-mature newborns. So the newborn initial skin that was in the water start peeling off after some few days, and it gets cleared off with time. So dark red color is usually common in premature newborns. Having them look dark red is premature babies. Cyanosis may be noted when there is hypothermia, infection, hypoglycemia, and with cardiac, respiratory, or neurological abnormalities. So for a baby with all these problems, you expect them to appear a little bluish. That's cyanosis. Acrocyanosis is peripheral cyanosis, of hands and feet and is normal in the first few hours after birth and may be noted intermittently for the next 7 to 10 days. Intermittently. Then you assess the baby for ecchymosis and petachy, which result from trauma after birth or trauma during birth. Then you want to assess the skin tegel over the abdomen, the skin tegel on the baby's abdomen, and you want to determine if the baby is dehydrated. Then you want to observe for forceps mark. If the mother had a forceps delivery, you want to assess for that. You also want to take notice of birth marks, which is normal. Babies will always also come out with birth marks. It is a normal mark. Let's look at the baby's abdomen, the umbilical cord. The umbilical cord should have 3 vessels, 2 arteries and 1 vein. 2 arteries and 1 vein. That's the umbilical cord. 2 arteries and 1 vein for the baby's umbilical cord. So if the baby umbilical cord has only 2, that's why when the baby is born, you assess the umbilical cord too. After delivering the placenta, you assess the cord. So if the baby is born with fewer than 3 vessels, you have to take notice and you notify the primary care doctor about that. So while a 2-vessel cord, 1 artery, 1 vein may present no problems or concerns, there's a higher correlation to intrauterine growth restriction and genetic chromosomal problems. So you want to take note, they have problems with that. Then small thin cord may be associated with poor fetal growth. Small thin cord shouldn't be small and thin. So you want to assess for intact cord and ensure that the cord clamp is secured after delivery. And you want the cord should also be clamped it should be clamped for at least the first 24 hours after birth. It has to be clamped the first 24 hours after birth, and the clamp cannot be removed when the cord is dried and occluded and it's no longer bleeding. You can, the clamp can be removed, cannot be removed. It can be removed when the cord dries up and then it's no longer needed, it's occluded. So once it's occluded, you are fine to take it out. Note any bleeding, drainage from the cord. We also have cord infections. So when you are cleaning it, you clean it as per the hospital protocol, and you also educate the mother about cord care at home. And you tell the mother, if the mother sees discharges, the baby has a fever, distension around the area, you want to bring the baby to the hospital or you want to send the baby to a primary care doctor. So you have to do cord care with the mother. You teach them to clean from down out, not from top down. Okay. So gestational, let's look at gastrointestinal. You want to monitor the cord for meconium stain. You want to monitor if there's meconium stain in the cord, assess for umbilical hernia. You want to assess for abdominal depression, which is associated with diaphragmatic hernia. Some babies are born with their cord on top of the bumpy hernia. They have hernia when they are born. So you want to assess for all that abnormalities. So you monitor bowel sounds within the first hour after birth. You monitor the bowel sound. The baby's anus, you want to ensure there's an opening for them to poop. So the first 2 will be the meconium, which should be passed within the first 24 hours. So for babies who are male and has to be circumcised, they wait for the first stool for the baby, the first stool and the first pee-pee, the first stool and the first urine before they do circumcision. You want to make sure the anal opening is well open, and you expect meconium to look a little black in the first 24 hours after delivery. So for the genitals, the labia is always a little swollen immediately after birth, and you expect some discharges or exudates inside of it. So for the men, you see the foreskin covering the glans penis. You see the scrotum, maybe edematous, and you want to verify that there's a meatus, the urinary meatus. You want to see that there's an opening on top of their penis that they can pee inside. So the testes are descended. You have to also check their testicles to make sure they have those small, tiny testicles at that time. So you also want to assess for hernia around that side, inguinal hernia around their thighs. The first voiding will always occur in the first 24 hours that you expect. The spine should be straight, posture should be flexed. You have to be supportive of the baby's head momentarily when they are in prone position, because remember, they are still soft, they cannot turn around. So, but they have to be well coordinated as well. And you expect hypotonicity or hypertonicity, which may indicate central nervous system damage. So if you have a degree of hypotonicity, the tones of the neck, the muscle tones of the baby's head is not correlating well with the body, you want to expect central nervous system problems. Let's look at the extremities. It has to be flexed, full range of motion, has to be symmetrical. The baby's fist has to be clenched, and the 10 fingers and toes has to be all be separated. It cannot be bind together like this. It has to be well separated. So you see them flex like that, especially with the reflexes. So you check them for any bow legs as well. Then you want to check their buttocks and the folds and the skin, the folds and creases around their buttocks. Check for any abnormalities. If you find any of that, you want to report it to the primary care doctor. Then the radial pulses. When you check their extremities, you should be able to feel pulses around them. They should be palpable. So slight tremors, when noted in a baby, may be a common finding, but could also be a sign of hypoglycemia or drug withdrawal in the baby. So if mommy was using drugs and gave birth to the baby, while you are assessing the newborn, you see their extremities, you notice some tremors there. Let's look at the body system assessment and the interventions. Let's look at the baby's cardiovascular system. You want to keep the newborn warm. You want to measure their apical heart rate for 1 minute. You want to listen to their heart sounds, and you assess them for oxygen saturation through a pulse oximeter. And if you hear heart murmurs, that's a cause for concern. Or if you are able to hear any murmurs. So you want to palpate their pulses. You want to assess them for cyanosis. This is their cardiovascular system, what you're looking out for. You observe for cardiac distress. When the newborn is feeding, are they struggling? You know, when they're having this open heart thing or hole in the heart, they do have problems with breastfeeding. So you want to assess them for all of that. Respiratory system, you want to suction the airway and make it patent for breathing with a bulb syringe. The bulb syringe is what you use, and I have mentioned that already. You want to also check for nasal flaring, which would be a sign for respiratory distress. You want to check for grunting and cyanosis bradycardia. You want to check for apnea. You want to check oxygen. If it's necessary, you can give them oxygen as prescribed. If you see that they are not breathing well, you can support them with oxygen. Let's look at the hepatic system. It's either normal or physiological jaundice, which will appear in 24 hours. So the first 24 hours after delivery, babies are at risk for physiological jaundice. They are at risk for physiological jaundice. And newborns and after first 48 hours in premature newborn. Jaundice occurring before this time may indicate early hemolysis of red blood cells. So jaundice that occur in the first 48 hours in either full or preterm babies is a sign of hemolysis of their red blood cells, and you have to report it. So jaundice is not an expected thing. You don't want it, but it do occur in children. So that's the hepatic system. The liver is impacted. That's when the babies turn yellow. So we have physiological jaundice, which peaks on above the 5th day of life. That's indirect bilirubin levels will rise. So you want to take notice of that. So you want to feed the babies. You want to feed the baby early to stimulate internal activities to be able to keep their bilirubin levels low. So you don't want it elevated. So you encourage feeding them early, especially breastfeeding will help keep them low. Breastfeeding will help with jaundice. So prevent chilling. You want to keep them warm as well, so that it will also help prevent jaundice. The liver stores iron, which is passed from the mother to the baby for 5 to 6 months. That's through breastfeeding. We have glycogen storage in the liver. The newborn is at risk for hemorrhagic disorders, coagulation factor synthesis, and the liver also depends on vitamin K. The liver also depends on vitamin K for synthesis. So you want to watch the baby for meconium stool and subsequent stools. You want to administer intramuscular dose of fetonadione to the newborn if prescribed for hemorrhagic disorders. It's a medication. It's usually 0.5 to 1 milligram if prescribed by the provider. So you assess the newborn's hemoglobin as well. Now let's look at the newborn's renal system. The immature kidneys are unable to concentrate urine. That's for the newborn. So a weight loss of 5% to 10% during the first week of life occurs as a result of water loss and limited intake. Okay, water loss and limited intake. Remember, they are out of the body, so you expect 5 to 10% weight loss within the first 1 week of life. So birth weight should be regained by 10 to 14 days after birth. So at least in the next 2 weeks after delivery, the first 1 week, you expect them to lose 5 to 10% because they are not eating enough and they are not getting enough. So, but within the next 14 days, which is 2 weeks, the next 1 week after the first loss, the next 1 week, they should be able to gain weight back. Okay. So if you keep checking their diapers and you wait to record them to see how much they are gaining. Now let's talk about the baby's immune system. You want to also know that the newborn has passive immune system through the placenta when they are born. That's the immunoglobulin G. They have passive immune system when they are born through the mother or through the placenta. So elevation in immunoglobulin will indicate infection in the uterus. If they are born with elevated immunoglobulin, to indicate there is infection. So you want to teach the mothers to ensure proper hand washing and ensure that an infection is free, the baby is free of infection. So as the nurse too, you want to monitor the newborn's temperature, and you want to observe for any cracks or opening in the skin. You want to administer eye medication within 1 hour after birth to prevent ophthalmia neonatorium. Ophthalmia neonatorium. Now to provide cord care, the cord care, you know, I had mentioned that the umbilical cord is supposed to be clamped, and the clamp can be removed after 24 hours of delivery. You can take the cord out after 24 hours. Then you want to teach the mother to perform the cord care on themselves. So teach mommy how to do the cord care. Usually they use alcohol to clean it from down in, from out, like in around the site and out of it. They should not clean from the top coming down. So you want to teach them the proper techniques as prescribed, and to avoid swallowing them. You also want to teach them how to put the diaper without getting the cord soaked, and you want them to at least not wet the area for the next few weeks before it heals. So usually the cord will fall off within 7 to 10 days, and then they will follow up with alternate instructions as provided by the primary care doctor. Now to provide circumcision care, we tell them to apply petroleum jelly. Petroleum jelly. That's, I would call it Vaseline to the penis, except when they need something different to use or something different has been ordered. But you remove the jelly cord, the petroleum jelly gauze, if it's applied after the first voiding. So if the baby had a circumcision, then I had mentioned that circumcision will be done within the first 24 hours after the baby has been able to poo-poo and pee-pee. They wait for the first urine and the first poop to make sure all those openings are patent before they will do circumcision. And after that, you want to remove the jelly if the baby poo-poo and is wet. So you teach the mother how to care for the circumcision site as well. You clean the penis after each voiding. You squeeze warm water on the penis. You put warm water on it to have it heal. Milky covering on the glans penis is normal and should not be disrupted. So you monitor for any urine retention, and you educate the mother and the caregivers that the newborn need to void 24 hours after the circumcision. So it is expected. Let's look at metabolic system and gastrointestinal system, metabolic and the GI. So newborns are able to digest carbohydrates, but they are not able to digest fat because they lack lipase in their system for the first few days of life. They don't have lipase. So proteins may be broken down only partially. So they may serve as antigens and provoke an allergic reaction. So the newborns also have a small stomach capacity. At least their stomach can take 10 ml at birth. When they are born, they can only take up to 10 cc after birth, okay? And this increase to about 90 ml per day within 10 days of birth. So the first 10 days of birth, they can only take up to 90 cc of liquid, imagine. So their stomach is very tiny. With rapid intestinal peristalsis, bowel emptying time is 2.5 to 3 hours. So every 2.5 to 3 hours, they'll be eaten. And because they have fast, rapid gastrointestinal peristalsis, it moves fast. Breastfeeding usually can begin immediately after birth, based on if the mother doesn't have any risk for breastfeeding, or there is no comorbidities, no restriction, the primary care provider can advise that. So bottle-fed newborns may be initially offered no more than 90 ml of formula. You give no more than 30 ml of formula in a day. So you observe them for feeding reflexes. Are their feeding reflexes well? Do they have the rooting reflexes, the suckling reflex, and the swallowing reflexes? You observe them for that. You assist the mother with breastfeeding, especially if it's a new mother, and also if there is a formula-fed mother, you should also help them. And this should be done every 2 to 3 hours. And formula for those who are formula feeding their babies. So a minimum of 30 ml or 1 ounce by day 3. By the 3rd day is fine, and should be done every 3 to 4 hours. They should give it 3 to 4 hours. They should not rush, or as per the primary care provider or the facility protocol. Then you want to frequently burp these babies because they swallow gas. You assess them for regurgitation and vomiting, and burping as well. So you position them on the right side after feeding. Position them on the right side after feeding. However, the side lying position is not recommended for sleep, because this position makes it easy for the newborn to roll to the prone position. And prone position is also contraindicated because it increases the risk for sudden infant death syndrome. So turning the head of the baby to one side is another option to do it. So after breastfeeding, then you can put them on their side. But remember, sleeping, they are not, it's not recommended for you to put them on their side when they are sleeping. It increases the risk for sudden infant death syndrome. So you observe for normal stools, passage, and meconium as well. So meconium, the color for meconium, which is greenish black with a thick, sticky towel. It should be like cold towel, like a towel-like consistency. That's meconium. It should be black, greenish, thick and sticky. So usually it's passed within the first 24 hours of delivery. So transitional stool, the second type of stool that is expected after the meconium, is greenish brown and of looser consistency than the meconium. So the first one is the meconium. This is black greenish. The second type is greenish and brown. and it's a little loose than the meconium. Meconium is thicker. Then we have the seedy yellow stool that follow next. And this one is usually noted in the breastfed babies. So newborn, pale to yellow light brown stool are usually seen in those who formula feed the newborns. Okay, so they have three types of stool. After meconium comes the greenish brown, and then comes the third color for formula fed. No, for the third color for the breastfed is yellow stool for breastfeeding babies, and for the formula fed is yellow to light brown. Now, you want to perform a newborn screening test, which include the phenylketonuria, the PKU test, if it is prescribed before the mother is discharged with the baby to go home. This one is after sufficient intake of protein occurs in the baby, and it should be mostly on formula fed or breastfed babies for the first 24 hours before screening. So babies should feed on milk, either formula or breast milk, first 24 hours before the PKU test is done. That's the phenylketonuria. You want to see how much the baby was able to absorb the protein. Neurological system, newborn's head size is proportionally larger than that of an adult because of the cephalocaudal development. So the fontanelles are open to allow for brain growth. You assess for abnormal size and bulging or depressed anterior fontanelle. You also measure and graph the head circumference in relation to the chest and the length. Okay, that's where you know the normal size of the baby. So you want to assess newborn's movement, taking notice of symmetrical and posture abnormality when they are moving. You observe them for jitteries, marked tremors, and seizures. So you test the newborn reflexes, you want to assess for lethargy, and you want to assess for high pitch cry. Thermal regulatory system, how they regulate their body temperature. The newborn should not shiver to produce heat, or like you see the newborn, they do not need to shake to be able to produce heat. Like you, an adult, you see yourself shivering. That means your body is trying to produce some heat. Newborns have brown fat deposits which produce heat for them. So you need to prevent heat loss from evaporating by keeping them dry and wrapped up in a blanket. So you don't want to have heat loss. So preventing heat loss results from radiation by keeping the newborn away from cold objects and outside walls. You want to prevent heat loss which result from convection by shielding the newborn from drafts. So you want to keep the room temperature too as well. And you take newborn's temperature auxiliary. You take them auxiliary temperature every hour from the first 4 hours of life, every 4 hours of the remainder for 24. So for the first 1 hour, every 1 hour, you check auxiliary temperature for the newborn. And after that, it's 24 hours. It's 4 hours. So first 4 hours, you check it 4 times. Then the next, from 4 hours of birth to 24 hours, you check it every 4 hours, or as per the policy of the facility. Let's talk about the newborn reflexes. So the newborn reflexes, we have the sucking and rooting reflexes. I'm going to start with the sucking and rooting reflexes. So what is the sucking reflexes and the rooting reflexes? So the sucking and rooting reflexes is for you to, if you touch the baby's lips, or you put your finger and you touch their lips or their cheeks or any corner of their mouth with a nipple, the newborn turns to their head. They turns the head towards the nipple, and then they start opening their mouth and taking hold of the nipple. They take hold of the nipple and they start sucking. So if you have ever seen, if you have a newborn, you can try them to see how this reflex work with them. So you see that you tap this way, you come here, you tap this way, and then they turn their head towards that way, and they start opening their mouth, looking for the breast on that side. So the rooting reflex usually disappear after 3 to 4 months. Take note. Rooting reflex disappear 3 to 4 months of delivery. Okay, but it may be persistent for up to a year. It can stay for up to a year, but usually 3 to 4 months, it disappears. Swallowing reflexes occur spontaneously after sucking and obtaining fluid in their mouth. That's a spontaneous thing. So newborns swallow in coordination with sucking without gargling or coughing or vomiting. So swallowing reflexes is an autonomic reaction to fluid in the mouth. They swallow it. Let's look at the tonic neck or fencing, tonic neck reflexes. So while the newborn is falling asleep or sleeping gently, or sleeping, you want to gently and quickly turn the head to one side. As the newborn faces the left side, the left arm and leg also extend outward, while the right arm and leg are flexed. When they are sleeping and you turn them to one side, you see that their left leg, and because you turn their head and their face to the left side, their left arm and their left leg will also extend outward. But the side that is the right side that is lying up will be flexed. So the head is turned to the right side. It happens opposite when you turn the baby to the right side. So you put the baby on the right side, the right arm and the right leg are flexed, outward. They are extended outward, and the left arm and the left leg are flexed towards the baby. We have the palmar plantar grasp. This is placing your finger in the baby's palm and they grasp it. They grab your hand like this. Okay. So, and the plantar grasp is their toes, at the base of their toes. So you go and you tap their toe, their foot. You put your hand and then place it at the finger at the base of their toes. You see their toes go curl. It will curl around the examiner's finger. They try to use their toes. They pull it like this all around you. They grasp it. So this one also usually, it lessens within 3 to 4 months. So within 3 to 4 months, it starts going down, and the plantar responses lessens in 8 months. That's the one with their feet, their legs, their toes, within 8 months. But the hands one, the grasping one, within 3 to 4 months, it go away. Let's look at moral reflexes. This one, you hold a newborn in a sitting up position, and then you allow the head and the trunk to fall backward to at least 30 degrees angle. The newborn assumes sharp extension, and then there's abduction. There's abduction of their arms with the thumbs and fingers in a C position. They make their hands and their thumbs in a C position. That is the moral reflex. So the moral reflex is, let me explain this one again. So you hold the newborn in a sitting up position, right? And then you allow the head to extend, the head and the trunk to fall backward to at least 30 degrees angle. So when you do that, the newborn will assume a sharp extension and abduction of their arms. So it's just like you think you are falling, right? So you assume a sharp extension position, and then your fingers will make a C position, your two. The thumb and the next one make a C position. And this is followed by an adduction to an embraced position. So your legs will follow a similar pattern, and their legs to try to follow a similar pattern. The moral reflex is present at birth. It's usually at birth and is present by 6 months of age if neurological maturation is delayed. By 6 months, you still have it. Let's talk about startle reflexes. This one is when you make a sudden noise, they become startled, they get scared. So the responses is present if the newborn is at least 24 hours old. So starting from birth, the first 24 hours old, they start getting that. So the examiner make loud noise or clap hands to elicit the responses. The newborn arms, they do this. They get so scared because something has happened. So they have to be able to respond to that. This is pull to sit responses, pull to sit. Now the startle reflexes will usually disappear within 4 months. It should disappear in 4 months. They cannot be scared all their life. So sitting up, the pull, the sitting up, the pull to sit response for the newborn is when you pull the newborn up by the wrist while the newborn is in the supine position. The head lags until the newborn is in a. I don't know whether you have tried this before. You have a newborn lying down. You came and then you hold them by their wrist. You use your hands to hold them, and then they try to flex themselves until they are in a sitting up position. That's the pull to sit newborn reflex. Babinski reflex or plantar reflex. So it at the beginning of the heel, or beginning at the heel of the foot. Uses a finger to stroke gently upward along the lateral aspect of the sole, and then move the finger along the ball of the foot. The newborn toes hyperextend while the big toe dorsiflex. The newborn toes will hyperextend while the big toe will dorsiflex. So assuming this is the baby's foot, right? Then you are stroking them here. So the big toe will dorsiflex, and the other toes will hyperextend. So the baby goes like this. Assuming this is the foot of the baby. So this one will also disappear in 1 year. And you don't want to have this absent. Stepping or the walking reflex. This one, you hold the newborn in a vertical position. Then you allow, like when you pick up the newborn like this, assuming these are the shoulders and I'm holding them, you see their legs. They do like some walking movement. You're holding them like this and their legs are going walking. So that's the stepping reflex. Crawling, you place the newborn on their abdomen. They begins to make crawling movements with their arms and their legs. So the reflex usually disappear after 6 weeks of birth. After 6 weeks of birth. Now the stepping or the walking reflexes will usually be present for 3 to 4 months of birth. The stepping is 3 to 4 months, and then the crawling is usually up to 6 months and it disappears. Now, newborn safety. Number 1, you want to put an identification bracelet on them. Newborn abduction. Newborn abduction. So the identification bracelet will include the name of the baby, the sex of the baby, the date, the time of the baby, the time that the baby was born, and the ID number. Sometimes they'll put the mother's information on the baby as well. So those are agency policies. So newborn abduction, the mother is taught to check the identification of any person who comes to remove the infant. So for you, the baby's mother, you have the right to know who is picking your baby. So you have to ask them to give you their ID. Can I look at your ID? Let me know if you're a staff here. So you look at their ID and let's say it's a patient care associate who has come to take the baby. You want to know who is taking your baby. So don't allow people to come take your baby. You want to teach their mothers your babies, you should identify whoever is coming for your baby. Now, parent teaching, you want to formula feed, you have to teach the baby how to feed the formula. So you teach them sterilization techniques if the water supply located in their area, where the purification, you want to teach them the purification process of the water, or if the water supply system has a problem in that area, you teach them how to make clean water for themselves, to boil the water and let it cool down. And then you want to teach them about the bottles too. They should also always microwave it and warm it, keep it hot. And then you also want to teach them how to birth the baby. From breastfeeding mothers as well, you want to teach them how to latch well. They have the baby latch well to the breast. You want to also help them to birth. Bathing, and you want to teach them to also drink a lot of fluid to have more breast milk produced. Bathing the newborn in a warm room before you feed them. So bathing the newborn in a warm room before you feed them. That's what you want to also educate them about bathing. You want to have all bathing equipment around. You don't want to finish bathing and you leave the baby out cold, uncovered. And clothing, you tell them to provide warm clothing so that they don't get hypothermic. And then you also want them to assess their diaper and change the diaper every as soon as it swells. Or when the baby is restless, you want them to also change the diaper. If the baby is being circumcised, you want to teach them about the care, the circumcision care that I have spoken about already. So let's talk about newborn preterm, the preterm newborn baby. So with the preterm newborn, your main concern is their body maturity. Your main concern is the maturity of their body organs, their body system, because a newborn is a baby that is born between 20 and 37 weeks of pregnancy. So I think I have spoken about this. You check their respirations, you check their lanungo, check their urine output, you check them head to toe to make sure all their body structures are intact. So you want to monitor their vital signs every 2 to 4 hours from birth. You want to maintain their airway and cardiopulmonary system and functions. You want to make sure their weight daily is working out right. They are feeding, mostly they'll put them in the warmer to keep them warm, depending on how early the baby was born, from 37 weeks. Then we have the post-term newborn. These are children or babies that are born after 42 weeks of gestation, post-term. They are considered overgrown babies. So you assess them for hunger, hypoglycemia. They may be hungry because they've been staying in that stomach for long. They can also come out with dry, patchy skin. So you also want to make sure you check them for skin. Their skin should be normal. Long fingernails, remember, overgrown. They have profuse scalp and hair, long and thin body because they've been there growing and eating. Wasting of fat and muscle extremity, meconium stain if possible, if it's present even in the baby's nails. You want to check for that. So you want to provide a normal care for these babies. You want to check for hypoglycemia, you want to check for aspiration. Let's look at small for age babies, small for age. So newborn who is plotted or is below the 10th percentile on the intrauterine growth curve. We have an intrauterine growth curve that every baby is supposed to fall somewhere around that. So a baby who falls below the graph has small for age growth. The baby is not up to the 10th percentile of their delivery. You want to question that. Now let's look at fetal assessment. Fetal assessment for small for age. We want to assess them for distress, fetal distress, and then if they have any fever, if they're having any fever, hypoglycemia, signs of polycythemia, there will be ruddy appearance, and then cyanosis join this, signs of infection, aspiration of meconium. You want to also intervene by maintaining their airway, checking their temperature, observing their vital signs. Let's look at large for age babies. These are babies who fall above the 90th percentile on the intrauterine growth curve. Those that will fall above the growth curve. So you want to assess them for any birth trauma, because respiratory distress and hypoglycemia. Monitor their vital signs for respiratory distress, and you also want to assess them for respiratory complications. So initial feeding still is well allowed. Let's look at respiratory distress syndrome. Respiratory distress syndrome. So we have serious lung disorder. Respiratory distress syndrome is a serious lung disorder that is caused by immaturity and inability to produce surfactant. The baby's lung is not able to produce surfactant, which results in hypoxia and acidosis. So when you assess this baby, they'll have respiratory distress, and this distress can include tachypnea, nasal flaring, expiratory grunting or retractions, and seesaw respirations, which I've explained before. They'll be pale and cyanotic, there'll be hypothermia, and they'll have poor muscle tone. What you can do for them is to monitor their skin color, respiratory rate, and the degree and effort of their breathing. You want to maintain airway patency. You want to support respirations as the doctor have prescribed. To give them oxygen, you give oxygen. You want to monitor arterial blood gases and oxygen saturation levels to make sure these babies are within limit. So you also want to also make sure that any premature newborn who require oxygen should be supported. You should give it to them as scheduled for an eye examination before discharging to assess for retinal damages. So any premature baby that is on oxygen, they have to do an eye exam before they discharge them. Even if it's not a premature baby, they do assess baby's eyes for vision. But for a baby that is premature on oxygen, you want to assess their eyes. Nutritional support, breastfeeding or formula feeding, you want to help educate the mother. So you prepare to administer surfactant replacement therapy that is instilled into the endotracheal tube to a newborn with respiratory distress syndrome. So they put a tracheal tube, you have to administer surfactant. It's the nursing function. So through the tracheal tube or endotracheal tube that will be placed. Let's look at meconium aspiration syndrome. This one occurs in post-term babies that are overdue, meconium aspiration syndrome. So the baby has stayed in the stomach for a while, they start eating from the meconium right now. So when the baby is born, you see that the amniotic fluid will be stained with meconium. So aspiration will occur inside the uterus or before the first breath. The baby will swallow the meconium before the breath will come out. Assessment, there will be respiratory distress, of course. Tachypnea, tachycardia, and all those symptoms you will see it. On their nails, you see meconium, their skin will be stained with meconium. What you can do for them is, if the newborn is delivered in an active cry and they have active cry, it's an evidence of, if the newborn have an active crying state with no evidence of respiratory distress syndrome or no evidence of respiratory distress, it is fine. You don't need to worry about that. So the baby is overgrown in the stomach, has swallowed meconium, but they are born and they are crying with a strong cry. You check them, their ABGA score appears normal. There's no cause for concern. You are only concerned if the baby is cyanotic, not breathing well, having respiratory distress, struggling to breathe. Let's look at bronchopulmonary dysplasia. Bronchopulmonary dysplasia. This is a chronic pulmonary condition that affects newborn who have experienced respiratory failure or have been oxygen dependent for more than 28 days. Newborn on oxygen for more than 28 days. The X-ray findings will indicate abnormalities that will indicate the areas of overinflation of atelectasis. It will be too much for their lungs to handle. That's not, their lungs are supposed to be able to do the work immediately after birth. So if immediately after birth is rather oxygen that is helping their lungs to expand, that means their lungs it's not been doing the work right for itself. And for the first 27 days, they start developing this pulmonary chronic problem, this bronchopulmonary dysplasia. It becomes a chronic problem for them. So when you assess such a baby, you see that they'll have tachypnea, tachycardia, retractions, nasal flaring, they'll have labored breathing and their crackles, decreased air movement, and occasional respiratory wheezing. What will you do for them? What are your interventions? You want to monitor their airway and their cardiopulmonary function. You want to provide oxygen therapy, fluid restriction, may be prescribed. Medications will include surfactant at birth and bronchodilators and possibly diuretics and corticosteroid. Let's look at transient tachypnea of the newborn, respiratory system conditions that from incomplete reabsorption of fetal lung fluid in full-term babies. This is a respiratory problem. The baby's lungs is not able to absorb any fluid that was left in there at full term or at delivery. So usually this will disappear within 24 to 48 hours after delivery. And when you assess them, there will be expiratory grunting, nasal flaring, fluid breath, sound, per auscultation, and cyanosis tachypnea. So you have to be supportive and give oxygen. This is what your nursing intervention would be. Let's look at intraventricular hemorrhage. This is bleeding within the ventricles of the brain. Intraventricular hemorrhage. Remember, the brain also has ventricles. It's not only the heart. So the risk will include prematurity, respiratory distress syndrome, trauma, and asphyxia. So when you assess them, there will be diminished or absence of motor reflexes. The baby will be lethargy. The baby will be lethargic. The baby will have apnea and poor feeding, high-pitched cry. You have high-pitched cry, seizure. You can have seizure activities. Your interventions is to be supportive. We have retinopathy of prematurity. This is another problem. We have vascular disorders that involve gradual replacement of the retina by fibrous tissues and blood vessels. This is the problem. The retina is being replaced by fibrous tissues and blood vessels instead of having it stand on its own to be able to see. The primary cause is by supplemental oxygen use. So if the baby has been using too much of supplementary oxygen, I have spoken about that already. So usually the intervention is to have a photocoagulation surgery, lesser photocoagulation surgery. So let's look at another problem, that's necrotizing enterocolitis. Necrotizing enterocolitis, we have acute inflammatory disease of the gastrointestinal tract. Necrotizing enterocolitis. So usually this occurs 4 to 10 days after birth and is most frequently seen in preterm newborns. So you will see that when you assess them, their abdomen will be distended. There will be increased abdominal girth. The bowel loop will be distended. There will be decreased or absent bowel sound. There will be bile stain vomiters. The baby will vomit with bile stained on it, abdominal tenderness, and then upper stool will be positive. To prevent this, you want to withhold feeding for 24 to 48 hours from the infant, believing to have you want to believe that the infant has suffered asphyxia, so you hold the milk. So breast milk is the preferred nutrient after this period. After holding the milk for 24 to 48 hours, we start them with breast milk. It's usually the recommended and preferred. The use of antibiotics with enteral feedings and breast milk has shown to have evidence of preventing necrotizing enterocolitis. So breast milk is good and is proven to be the one that helps treat it. Prevention, you want to help administer corticosteroid to the mother prior to birth to promote early gut closure. Promote early closure and maturation of the gut stomach mucosa. Then you want to hold feedings, as I said. You want to insert NG tube to help them to eat. Eat. You want to give IV antibiotics and IV fluids and electrolytes to help with fluid imbalance in the body. Surgery is recommended if it is scheduled. Then let's look at hyperbilirubinemia. Hyperbilirubinemia. That one is elevated serum bilirubin. So because the serum bilirubin is elevated, the therapy will be aimed at having it within the normal limit. So you assess the baby for joining. Remember, when you talk of bilirubin, it's about the liver and then you start thinking about jaundice. So the baby will be jaundice. They'll have elevated levels. They are enlarged liver. They'll have an enlarged liver, poor muscle tone, lethargy, and poor sucking reflexes. So the elevation should be is indicated when the serum levels are greater than 12 milligram deciliter. If the baby's bilirubin level is greater than 12 milligram per deciliter, you are concerned. So you want to monitor the presence of jaundice, you assess the skin and the sclera of the baby, and then you examine the newborn skin and you expose them to natural light. You want to expose them to natural light. You want to keep the newborn well hydrated as well, and then you want to let your aim for this is to have the jaundice actually go away. So you want to facilitate early and frequent feeding to help them pass meconium, and you also want to report to the primary care provider any jaundice that appear within the first 24 hours. So you want to prepare the patient for phototherapy, the phototherapy blanket, and then you monitor them closely during that kind of treatment. At any serum bilirubin level, the appearance of jaundice during the first day of life indicates a pathological problem, okay? At any level, if jaundice appear anytime after birth, it will just indicate something going on. Phototherapy, this is when the baby's bilirubin level is high and you're exposing them to light to have them come back to normal. So usually the treatment for bilirubin problems is to give phototherapy. So I also sepsis. I also want to talk about sepsis. So sepsis is generalized infection in the newborn when there's presence of bacteria in the blood, such as group B streptococcal infection. So the baby will be pale, tachycardia. I think I have spoken about this one before, and there will be fever as well. So you know when the baby has all these problems, monitoring intake and output, fever, vital signs, and all that is included. Let's talk about the touch infection. That's the syphilis and the other STDs that are added. I'm going to jump this one because I know I have spoken about it. So I'm going to go straight to addicted newborn. Addicted newborn. So a baby that the mother has been taking alcohol. So it's a newborn who can become passively addicted to drugs that have passed through the placenta. So if the mother has been using drugs, it can go through the baby will be born as an addicted newborn. So you assess their assessment findings and you see that the baby will have withdrawal, and this may vary with time depending on the specific addicted drug that the mother was using. So we have that as part of the fetal alcohol syndrome or fetal alcohol problems and disorders. This will be in pediatrics as well. But when you assess this baby, the baby will have a high-pitched cry. There will be tremors, irritability, diarrhea, fever, sneezing, vomiting, respiratory problems, seizure, poor feeding. So you want to monitor this baby. Let's talk about fetal alcohol spectrum disorders. This will also cover part of this fetal alcohol syndrome I just finished talking about. So for a fetal alcohol spectrum disorders, these are several disorders that come together for baby that the mother was taking alcohol. So they are a group of conditions caused by maternal alcohol use during pregnancy. The disorders are a result of teratogenesis, and they cause cognitive and physical delays in the baby. Physical alcohol syndrome, it is also most severe for babies. There are also babies that have fetal. There are also fetal alcohol affected babies. And the other disorders that will include will be alcohol-related neurodevelopmental disorders and alcohol-related birth defects. Remember, so they have facial changes when you assess them, short palpebral, they will have short palpebral features. Their body features will not look normal. They'll have a flat face or flat mid face. They'll have thin lips. They'll have low nasal bridges. Remember, abnormal palmar creases. You see their body creases will not look normal as it should be for a newborn. Irritability and hypersensitivity to stimuli. They'll have a high cry. Tremors, poor feeding, and seizures. So you are supposed to monitor them for respiratory and all these suckling reflexes. You have to make sure they are all developed. So newborn of a mother with HIV/AIDS, I think I spoke about this. I am not gonna go into details with that, but there's the need for weekly non-stress testing for 32 weeks of gestation when a mother is HIV positive. So the mother will have to be doing fetal stress tests to check the baby and how the baby is growing. So delivery to, they are careful of transmission across the placenta. So during childbirth, they also do not allow the mother to breastfeed. Breastfeeding is not done in the HIV mothers, especially if the healthcare provider ordered it, and it's not recommended to breastfeed if the mother is HIV positive. Then they start the baby with immunizations right away as well. I want you to go back to that video. I spoke about that, problems with maternity or problems with the maternity patient. They are all there. Newborn of a diabetic mother, I think I also spoke about this, but the baby, you are worried the baby will be hypoglycemic when they are born. So you also try to take notice. That's under pre-gestational diabetes. I spoke about it. So they will become hypoglycemic. You are worried about that. Let's talk about hypothyroidism in newborns. Hypothyroidism is decrease in production of thyroid hormone. So the baby will be born with protruding or thick tongue, dull look, swollen face, decreased muscle tone. Laboratory results will reveal low thyroid production. So you want to focus on thyroid replacement. Relief of choking in an infant. Choking is also is when a foreign body obstructs the baby's airway. So they have signs of mild airway obstruction, which will include gas exchange problems. They'll be cyanotic, oxygen cannot flow freely within them. Now, the priority nursing action, what will you do for a baby who is choking? So you see that the baby is feeding and they're having choking, they're not swallowing well, they're just struggling. You want to sit or kneel with the infant on your laps. You kneel down or you sit down with the infant on your laps, and you remove their clothing. You remove the baby's clothing, especially those around the chest if it's easily removed. Then you want to hold the infant face down. The infant is face down. So after you held the infant's face down with the head lower than the chest, so you put the head lower than the chest, the baby is choking. The head should be lower than the chest. On your arms, on your forearms. So you hold the head to be lower than the chest on your forearms. Remember, the body should be on your thighs or on your laps when you sit down. So the forearms is rested on the thigh to support the infant. Then you deliver 5 back slaps between the infant's shoulder blades, using the heel of the other hand with support force. The heel of the other hand with support force. Then you place free hand on the infant. Place your hand on the infant back while supporting them. So if all these things does not relieve, it does not have the baby, the choking substance come out, then you want to start CPR. So if infant becomes unresponsive in the process of you trying to relieve them from the choking nature, then you want to start CPR, resuscitation, while checking for the foreign body each time you provide airway opening, and you do not perform a finger sweep. Don't put your finger inside the mouth because you might push the thing deep down in the throat. So you don't want to do that. So For a CPR guidelines for an infant, you want to include an individual who is infants. This should be done in infants. No, CPR. I'm going to talk about the cardiopulmonary resuscitation for infants. So these are infants or individuals who are 1 year of age or above. Then you use the basic life support. You use the BLS. So the life support for infant is very similar to that of a child. The basic BLS for an infant is, or a baby, is that of a child. So it has guidelines telling you what to do. First of all, you want to check to locate if the baby has a pulse. If there is no pulse, then compression technique is to be used, 2 fingers for a single rescuer, and you use a 2-thumb circling technique for 2 rescuers. So compression depth should be 1/3 of the chest width, which is approximately 1.5. So the compression length, when you pressing it, at least 1.5 to 4 inches, to 4 centimeters. 1.5 inches to 4 centimeters is allowed for a baby. The compression to ventilation ratio for 1 rescuer is 30:2. And for 2 rescuers, it's 15:2. So the emergency response team should be activated if the arrest is not witnessed and the rescuer is alone after providing 2 minutes of CPR. So after 2 minutes, the single rescuer can activate the emergency response system and get an automated external defibrillator. So the emergency response system should be activated and you get the defibrillator to use, okay? So these are what you will do for a newborn that is having respiratory distress, So on this note, this brings me to the end of this discussion. I want you to further study how problems that have to do with the newborn, and this is how you also care for the newborn. Thank you so much for staying with me. I know it's been a super long video, but you can always repeat any portion of this video that you want for your understanding. So this brings me to the end also on maternity nursing. So we are done with maternity nursing, and I have gone through several different videos on maternity nursing on several topics. Please do look for all those videos and watch them. They are good for your preparation, for your content knowledge. And you can reach out to me if you need any further help and any further explanation. But take notice of the CPR guidelines I just spoke for the babies. For 1 rescuer is 30:2 breaths, and for 2 rescuer is 15:2 breaths. And after 2 minutes of providing CPR, you activate the emergency response team and you get an external defibrillator for the baby. Please let me know if you need any further help. Thank you so much, and watch out for other topics and other videos. And I wish you luck as you prepare for your NCLEX. Please do practice questions with your content knowledge and enjoy your day. Goodbye.